This podcast is sponsored by PAX. Whether on water, on land or in the air, PAX bags are both versatile and flexible backpacks that are perfectly suitable for your requirements in the most demanding of environments. PAX bags are highly regarded due to their exceptional performance in pre-hospital and in critical care environments. Renowned for their durability, they endure harsh conditions while providing rapid and reliable access to essential kit. So their well-organised compartments and customisable configurations enhance efficiency in high-stress situations. PAX bags are designed with infection control in mind and are easy to clean and disinfect. Their highly visible colours and reflective strips add quick identification and adherence to quality standards, assuring reliability. The versatility of PAX bags caters to a diverse EMS providers, but also delivers vital equipment and durability and ease of use for pre-hospital critical care services globally. I've used PAX bags in a number of critical care situations and they're absolutely excellent. Please see the show notes for further details.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the Pre-Hospital Care podcast. So welcome to 2024 with the podcast. We've kicked the new year off with a new hosting team. So there's going to be 5 different hosts now, all from a vast array of experience and indeed backgrounds. And that's what that's going to do is expand out the guest selection, expand out the perspectives on the podcast as well. So when I started this podcast, I really wanted there to be a platform for different voices. And that's exactly what we're going to do in 2024. And we're going to start this week actually with Alec Wilding's perspective and indeed fantastic interview with Ben Mckenzie, and that's just about to come up now. We've also got a new image for the podcast, a new thumbnail, and that's thanks to Sylvia Eagles. So thank you to Sylvia for designing a new fresh image for the podcast. And finally, we're going to start with a early access subscription model for additional content. So we're still going to produce free content every Monday at 5 a.m. GMT is going to drop a new episode which is absolutely free of charge, and we are going to do an early access subscription model for additional content to this, and that will become apparent as the year carries on. But what we still want to do is bring you subjects and indeed guests which are subject matter experts in their field of practice, and just informative content which was really engaging and indeed that you learn from as well. This next episode that Alec has recorded is probably one of the most important episodes we've hosted on the podcast. It's extremely moving, and Dr. Ben Mckenzie talks candidly about his 15-year-old son that died from life-threatening anaphylaxis. It's a powerful episode. You will learn a lot from the episode, and it's a really important conversation. It's important to have these types of conversations on the podcast. It's just worth bearing in mind that you should still practice the algorithms and indeed the treatment protocols in your service. So we are advocating the protocol and indeed this approach, but it's prudent to stay compliant within the framework and guidance within your service. Please do enjoy this profound episode with Alec Wilding and Ben Mckenzie.
Welcome back to the Pre-Hospital Care podcast. In this episode, I'm joined by Dr. Ben Mckenzie. Ben has been a mixed consultant in both adult and paediatric emergency medicine in Victoria, Australia for over 15 years. He's also spent considerable time as a director of emergency medicine training and as a retrieval specialist. In 2021, Ben's 15-year-old son, Max, passed away following an anaphylactic reaction. Following Max's death, Ben started a PhD in resuscitation algorithms, which led to the creation of the AMAX4 model of care for anaphylaxis and asthmatic emergencies. His campaign is causing waves in the critical care community around the world and is challenging current guidelines on resuscitation for this unique group of patients. Welcome to the podcast, Ben.
Thanks, Alec. It's really nice to be with you, and thank you for inviting me on.
Yeah, thanks very much for your time. Really keen to get into it. So, Ben, would you mind starting us off and telling us a little bit just about the epidemiology of anaphylaxis?
Yeah, so I thought I might just walk everyone through anaphylaxis. Anaphylaxis is super common, and as you and I, like we all know someone who has, is at risk of anaphylaxis. In Australia and the UK, it's one kid in every classroom. So if you're looking at the paediatric incidence or prevalence, then that's what it is. So it's never very far from our own personal worlds, and that high number translates to our work, right? In emergency care, it's common. Now, in terms of actually giving you formal stats, it becomes a little bit difficult. I mean, depending on whether you're pediatric or adult, and also how you define anaphylaxis. And I think this is one of the really important things that I'm talking about on this sort of journey, is saying that anaphylaxis is just a subset of this IgE-mediated reaction, or type 1 hypersensitivity, or acute systemic allergy, whatever you want to call it. Anaphylaxis is just the severe part, which really involves airway, breathing, circulation. And we even get a bit muddled because we say, oh, if it's prolonged gastrointestinal symptoms, we call that anaphylaxis too, according to the World Allergy Organization. So what I try to do is say, everyone, don't stress too much about the definition of anaphylaxis. If someone's been exposed to something and they've got acute onset of allergy symptoms, whether that be diffuse skin redness or oropharyngeal symptoms of itch and feeling like your throat's closing over, or to the airway, breathing, circulation type symptoms that we all worry about. It's a spectrum from itch to death, and that's really important. And so not all allergens are created equal. So if you eat if you're allergic to cashews and you eat a tiny bit of cashew and you just get really itchy and your mouth gets really itchy out of that, you're at risk of dying from anaphylaxis next time you have it. And we know that people who die from anaphylaxis, almost all of them have had a previous reaction. And most of them know that they're allergic. So often, I think when we're talking about anaphylaxis in a general concept, that's the most important thing. It's a spectrum. Anaphylaxis is like the severe end, but we need to appreciate that even the small reactions are important to recognize, because then those people need follow-up and they're risk managed. I don't know, that's a roundabout answer, but I think that's an important concept.
No, definitely. And you talk about this spectrum, Ben. It's much more than just a description, isn't it? I know from your lecture series, there's a Delphi study in America, is that right, where they formally categorized this spectrum. So it's much more than a description, is that right? From what we might typically think of as mild to life-threatening anaphylaxis. Is that correct?
Yeah, it's totally a spectrum. And what we're actually trying to do, so in one of my registry projects that I'm working on in my PhD, we've actually developed a matrix where you tick the box according to airway symptoms, breathing symptoms, circulation system, gastrointestinal, skin, etc. And you just tick the box of severity. And because there's so many grading systems, but what you actually want to do is capture the reaction. And if that's pure asthma, bronchospasm symptoms, then that's really important to know, because we want to be able to study that and understand how much impact that is. So it's really about describing the symptoms. And because then if you just say it's anaphylaxis, then you lose this whole amount of meaningful description when you hand over to the hospital, or you hand over to your colleagues or whatever, or you want to research and study it.
And I know anecdotally these life-threatening presentations, they're typically quite rare, aren't they? That's anecdotally, but I know from the data as well. Is that true? But generally, cases of food allergies are on the rise, certainly in the UK. Does this mirror the picture in Australia? And what's the latest thought behind the rise in cases?
In most industrialized countries, the incidence it's becoming more common. We don't really know why that is. In Australia, in allergy circles, a decade ago, there was a push to not introduce allergens early in childhood, and now there's a push to introduce allergens much earlier in infancy, to see if that is actually part of the problem, or this hygiene hypothesis that we live too cleanly. And the reality is we just don't understand. And now that we're in Australia, we're introducing things, allergens more early. It's just shifted the first anaphylaxis or allergy presentations to a much younger age group. Will that translate to less allergies as they get older? We don't know. So we're still in the process of sorting that out. But In terms of, it is worth pointing out that deaths from anaphylaxis are rare, and and there's a few reasons behind that. One is everyone tries really hard not to get exposed because the main treatment is allergen avoidance, and our healthcare systems are really good, and there's availability of EpiPens. So we've put in all these processes where we address food labeling, or even for the insect venoms, we use desensitization to bee and wasp venoms. So we try all of these things to really try and keep the mortality rate low. So the mortality rate is low, but that is not just a passive process. That is because everyone's working bloody hard to keep everyone safe, and it takes a community to do that properly. But it might be a good chance. I don't know if this is the right time, but it's kind of important to say, one, it's rare, and also the one thing that happens with anaphylaxis is we get lulled into this false sense of security, because the reality is that 90% of acute allergy or anaphylaxis cases need 0 or 1 dose of intramuscular adrenaline. So it's not 9 times out of 10, you're going to give someone a dose of adrenaline and they're going to be fine. And then 10% of cases in emergency departments end up getting 2 doses. And then a subset of that 10% end up getting more than 1 dose, and it's small, it's less than 3%. And then the number that go to ICU are smaller. So in adults in Australia, there's only 500 ICU admissions per year that, stay sick and end up having to go to intensive care. So that pointy end spectrum is really rare, but actually these people are often really young, healthy, and if you can keep them alive for 8 hours, they're going to walk out of hospital the next day or the day after. And that's what the data in Australia shows, is that in ICU admissions, they don't stay in ICU for very long, almost all of them, because if you've intervened appropriately and given the brain oxygen and blood pressure, then those people get better. The anaphylaxis curve only goes for 4 hours and sometimes a little bit longer, but it's short-lived. And if you can keep them alive during that time, then they're fine and they're back to normal and they're out the door the next day or the day after. So ICU admission is very short, usually less than 48 hours. So it's worth noting that the sick cohort are rare, but if you do a good job, they're totally, it's reversible. Like, these are people who'll be back to normal if you can manage to keep them alive for that short period of time.
And I think that's such a key point, is that early recognition, early management, early treatment. And I think we'll get onto the algorithm in a bit, and I think that's easily one of the standout. And this is for the very sickest end of the spectrum. But even then, at that point, with really good aggressive management, exactly as you said, beautifully illustrated there, this is something that could be really easily reversed. There's been some high profile deaths due to anaphylaxis in the UK recently. Why do you think that healthcare practitioners often under triage these initial anaphylactic presentations, and how fast can these mild presentations become life-threatening? And also, I know from your lecture series you've talked a little bit about hypoxic brain injuries being silent, and we need to be looking for the cues. So again, another question would be, what are the cues, all kind of blended into one?
Yeah, so I think in terms of the severe end of anaphylaxis, I think what the cue needs to be. So I think just before we started the podcast, Alec, we were talking about the difference between asthma and anaphylaxis, and it's probably important to a couple of things here. One is that anaphylaxis in food allergy is almost always a respiratory death. The best and most robust data actually comes from the UK, from a chap called Richard Pumphrey, who published 24 years ago now. He published the mechanism of cardiorespiratory arrest in the UK fatal anaphylaxis registry, and he basically got a picture of what happened to these people, and all of the food allergy people died from either airway edema or bronchospasm. Now, in terms of your question about how quickly that occurred, it's always within the hour, almost always. But it's symptom onset is that rapid, but 15 to 30 minutes, things can come unstuck. You can be arrested from a food allergy during that time. In terms of stings, if you're going to arrest from a wasp or a bee sting, then that's often much quicker. So that's sort of 0 to 15 minutes. And the same with intravenous drugs in anesthesia. That's usually a couple of minutes before you get onset of severe symptoms, and up to 15 minutes before arrest. So, but it's kind of how quickly do these things? If you're a paramedic and you're going to a bee or wasp anaphylaxis, if you get there and the patient's still alive, you're probably going to keep them alive because they haven't collapsed and lost their output and become acidotic. And so they're either going to live or die kind of thing. Their blood pressure is 60, you're going to give them an adrenaline, it's going to work out. Whereas but with the asthma ones, the food ones who have got this airway edema, that they've usually got time to call for help and know what's going on. And paramedics might often arrive as the wheels are falling off because you've got time. So the insect ones are probably going to die before you get there, but these food ones are going to die on you almost if they're going to die and be in that category. So how quickly can that happen in front of your eyes? 15 minutes. And that's what happened to Max, and we can talk about that. So that's how quickly it happens. And why do we underestimate it? Well, it's because we're so used to it getting better with minimal treatment. And the severe cases are rare, but there'll be someone listening to this podcast who it'll happen to, and they've got the opportunity to save someone's life. And so, that's what we do. We always prepare for the rare situations. Especially these people are often young and got their whole lives to lead.
Thanks, Ben. And I know you touched on it there, and I think it'd probably be a really good time to share Max's story. And I just want to say that I can't begin to imagine what it's like to lose a child. I think it must take an incredible amount of courage to do what you're doing, to regularly share your story and tell everyone about what happened. But it's incredibly compelling for healthcare practitioners such as myself to hear the other side and a reason to remember why we all do what we do, and to reflect so that we can be better. But would you mind sharing what happened to Max?
Yeah, I can. And it is really hard. And my heart goes out to anybody who's lost a child. It's a special type of pain. So what happened to Max is, so Max was a healthy 15-year-old kid. He was awesome. He totally loved life. He was getting involved in everything at school. He was doing competitive sort of flat water kayaking. He loved it. He had a great group of friends. And he died from anaphylaxis, and his 15-year-old friends had to lower his coffin into the ground. And that is something, and that is really hard for those boys, but they're incredibly brave. So Max was at his grandma's house, and he ate some apple crumble which had some ground walnuts in it, and he ate it because it was from some catering that his grandma's business had cancelled or had brought home. So she gave it to him, and he ate it, and rapidly he got symptoms, and he's had some mild reactions before, like every other anaphylaxis death. He's had some mild reactions. So but his asthma, his manifestation was just asthma, as well as some itchy eyes, and he had some tummy tightness. But for all intents and purposes, for the paramedics who arrived, he just had asthma. And when there was a paramedic crew that was an instructor and a graduate paramedic who was in their first week of work, and they attended Max, and they said, "Max, it looks like you've got asthma," because he had that prolonged expiratory phase. We've all seen it before. And he said, no, this is too quick. This is anaphylaxis. And he wasn't sure whether it was the apple crumble because it didn't have labels on it. But then what happened was, so he told everybody the diagnosis, and he wasn't unwell. In fact, his first oxygen saturations were 97%, but then over the next half an hour in the care of paramedics at his grandma's house, he became progressively and linearly hypoxic. So shortly after his sats were 97, then they were 93, then they were 88, then he was needing oxygen and they stayed 88, and then they went to 83. And there's in Australia, in Victoria, we have this system where paramedics can call for the intensive care paramedic to come and do some backup, but you can't intubate as an intensive care paramedic unless there's 2 intensive care paramedics, but they drive in solo vehicles. And so there were some logistical problems, and it took 30 minutes to do a simple extrication and get out to the ambulance. And in the ambulance on the way to hospital, Max said, he yelled with his mum in the front seat, said, I'm going to die, which is a really common thing for people who have got severe asthma to say, because they know that they can't breathe and they're going to die. And so 4 minutes from the hospital, he said he was going to die, and he became unconscious and had a brief hypoxic seizure, a brief episode of bradycardia, which got better with mask ventilation in the back of the ambulance. So when he arrived in hospital, he was hypoxic. He was GCS3. He may have been having some hypoxic seizure activity, and the first SATS reading was 43%. And that had been probably going for 5 or 6 minutes. So there's this opportunity now. We can talk about all the opportunities for escalating care pre-hospital, if you like, or we can talk about what happened in the emergency department. The emergency department's very straightforward. You're faced, this is what the AMAX4 algorithm is designed for. So if you have someone who's unconscious, needing assisted mask ventilation from either in anaphylaxis or severe acute asthma, which may be anaphylaxis, because they look the same at the beginning, then that's when this algorithm applies, and it really requires an emergency tube that is rapid, and we can talk about that. So that's what happened to Max, and so Max wasn't intubated for 23 minutes. They gave the emergency department weren't sure what to do. He already had IV access from the paramedics. Then they decided to call a code blue and get the anaesthetist down. And then and that all took 15 minutes. They decided to get an adrenaline infusion. They gave him some intramuscular adrenaline. They gave him some midazolam because they thought that was for the seizure. But they didn't make any efforts to intubate until he became bradycardic and asystolic. And I think it's really important that we all are able to recognize what a hypoxic arrest looks like. And I'm sure we've all seen it, where you get someone who's hypoxic or got no blood pressure, and it's not VF usually that you get, it's just a sinus bradycardia. And we know that very well in pediatrics, because we call anything less, heart rate less than 60, we call that a cardiac arrest. But it's the same for any young person or anyone who's got a heart rate of 140 and then suddenly becomes 60. That's a cardiac arrest because they're not getting enough oxygen. And that's what happened to Max. So he's in the emergency department for 15 minutes. He's got a heart rate of 140, and eventually their treatment fails and they start CPR for bradycardia. And then all of a sudden, intubation is very difficult. And it's still unclear whether intubation was difficult because it was just suboptimal. There was a bit of vomit in the airway, that there was CPR going on, or whether or not he actually had some laryngeal edema. And it's unclear, but he certainly had no airway symptoms when he said, I was going to die 6 minutes before arriving in the ambulance. It was in a clear, panicked voice. So it's kind of fascinating thinking that you could be in a team where it takes 23 minutes for someone who's in extremis, who clearly needs intubation, and intubation's indicated for a number of reasons, but yet it takes 23 minutes to achieve that, and that's just too long. And we need to be very clear as a critical care community that that's not acceptable, that we don't do that. And I think that leads into your next question, Alec. But that's what happened to Max. And so Max I arrived at 16 minutes. Oh, 16 or 7. Uh,
You were on duty, is that right, Ben? At a
yeah,
different
so
hospital, and you
uh,
attended.
I was actually coordinating retrieval for the state of Victoria on that day, and I got panic text messages from Tamara. And so a paramedic, one of my colleagues, actually drove me lights and sirens to the hospital, which was very kind and slightly against the rules. But we drove there, and I arrived to this scene where there was no team leader. The team leader had started CPR, and then so there was no team leader. I had to become the team leader. And after the third attempted intubation, and I watched this person just pull out the tube after a failed attempt, which was clearly esophageal. I said, he needs a surgical airway. He needs a scalpel finger bougie, get the scalpel. And the nurse went and got the scalpel from a trolley at the entrance to not from the difficult airway trolley, but from the trolley at the entrance to the cubicle, and walked across, and this intensive care consultant made the cut, but then was on the head side of the bed, which is on the wrong side, because nobody was helping her. And so I actually had to walk around next to Max's neck and put my finger in his neck and put the bougie in for the training team. And I still have flashbacks about that to this day. And it's just not a father's job to direct an emergency airway and to complete it when it's not being done in the best fashion. So I guess that's what happened to Max. He lived for 13 days, and actually he there's a particular pattern of hypoxic brain injury which is very predictable, and he was going to be very disabled, but he could still hear, he could still poke out his tongue when you asked him to, but then his brainstem instability meant that he braddied out one day, and he had some CPR, but he died, and that was 13 days later. And so we had to watch this poor Maxie just being in ICU and realizing that his life was never going to be the same again. And yeah, it's pretty tough.
It's just listening to you talk about it and go through it, Ben. It's honestly so powerful, and I think it's almost the epitome of tragedy. I really do think that. But if anything positive was going to come out of what happened to Max, I think all of the work that you've done in the algorithm, which we're going to get into now, and talk about, it's such a fitting tribute. And there's so many bits to the story there from clinically, from a clinical point of view. I think we can all sit here listening to what's happened, the team that have been involved in Max's care, and think that this wouldn't happen to us. But the simple cold light of day is that there has been a number of cases where very experienced clinicians and good teams who've got out of bed in the morning with no other intention than to try and help people have found themselves in these situations. And I think it's all the more reason why it's so important to pick it apart so that we can all learn from what's happened. So I thank you again for sharing your story. There's a lot of the obvious parallels here from what you said are the now sort of infamous case of Elaine Bromley, and all the fantastic work that Martin Bromley went to, again, to share her story. What do you feel are the key learning points here from, I don't know if there's been an investigation yet from the hospital's point of view, or if the guidelines were followed in particular to that hospital, but and I know this is obviously leading into your algorithm, but were there any immediate things that came out of the investigation?
Well, I think one of the point that you just made is very important, that nobody wants to come to work trying not, without wanting to do their best. Everyone comes with the best of intentions. Everyone wants to do a good job, and but things still go wrong, and that can be for a variety of reasons. And but that is important. So when I had contact with Martin Bromley after this, we sort of had a discussion, and there's some pretty obvious parallels. In fact, the attempts to intubate Elaine were actually less than Max's, and so but there is these extraordinary parallels, but it's perhaps in a different setting from elective theatre to emergency resuscitation. But I think critical care has evolved over the last decade or two, where we really do have the potential to deal with these cases and the capability to deal with these cases. It just requires a bit of forethought and some tools to use when you're in the thick of it and thinking's really hard. So we need something to fall back on because we're all a bit overwhelmed and there's lots of cognitive things that we have to deal with. And I guess that's the thing to say about the AMAX4 algorithm, is it's not actually anything new in terms of medical concepts. None of the drug doses or none of it's anything that I've invented. I've just trying to put it together for this unusual circumstance, which is really unique and needs a specific set of interventions to save somebody's life that is a little bit different to other situations. But it really can save someone's life, and there's this time critical human factor element to it, which needs integration into an algorithm. So that's why there's certain parts of the algorithm is to try and support humans to reach their full potential and the things that they want to do, which is exactly why we all come to work.
Yeah, and like I said, I think it's a great piece of work. We'll get into it. We can talk about the actual algorithm now. One of the first parts of the AMAX4 algorithm is an advocacy for IV adrenaline over the typical standard of care at the moment, which is intramuscular adrenaline. Just to quickly, would you be able to clarify exactly what group of patients the presentation? I know you mentioned it earlier, but just to confirm, which specific group of patients the algorithm's designed for, and then just talk a little bit about the changes to drug route administration for adrenaline.
Yeah, sure. So the first thing to say about adrenaline is that, as we said before, IM adrenaline gets you out of 90-something% of cases. It gets you out of trouble. But the important thing to know about intramuscular adrenaline, and these are based on studies that are, with high pressure or adrenaline or auto injectors in well patients, is that it takes 5 to 8 minutes to get peak adrenaline concentration. So it's not an instant thing. So if you're talking about someone decompensating over the space of 15 minutes and you're at 13 minutes and you give them IM adrenaline, not going to help you get out of the situation, because we're really down to minutes in these situations. So remembering that IM adrenaline takes 5 to 8 minutes in an unwell patient, that may be much longer. If you've only managed to get it subcutaneous, then that'll never work, because we know subcutaneous adrenaline's it's kind of placebo-like, and that's borne out in studies where you measure adrenaline levels. So if just relying on IM adrenaline for these very sick cases, then we're in trouble. One, because it takes too long. 2, because absorption might be delayed in a sick patient, and we have no idea. There's no data to tell us whether it is or not anywhere in the world. And 3, we might have given it subcut, and it might have been a short needle that we used, and it wasn't a big long EpiPen needle into the thigh. And so we might not have as much adrenaline as we think we do. And then if we're really trying to keep someone alive because they're saying, I'm going to die, then we need something that's going to work instantaneously, and that's intravenous adrenaline. And so that's where it comes from. Now, to avoid unintended consequences, I have, because we don't want to cause harm with any algorithm, I have explicitly said that this algorithm is for people who are unconscious requiring bag mask ventilation, because then if you're in that group and you've got anaphylaxis, you're in trouble. That's a disaster. You need every help, every minute and an ounce of help you can get, and you need it now and not in 8 minutes time. And so that's where the IV adrenaline dose comes from. The dose for this situation is 1 microgram per kilogram, or if they've already had their bradycardic arrest, you can use the cardiac arrest dose. But remember, 1 microgram per kilogram is just 10% of the cardiac arrest dose. You have to give that 10 times before you even get to the bradycardic situation. So particularly in young people, it's very well tolerated. In older people, IV adrenaline has historically been associated with some problems like AMIs and intracerebral bleeds if given in the wrong dose in the wrong time. But the APLS, the Advanced Pediatric Life Support course, advocates, well, at least in Australia, it advocates for 1 microgram per kilogram every 30 seconds to 10 minutes. And that's where that dose comes from. And it's a good dose to have up your sleeve because you sometimes just need help on the end of the needle. And that's how you get help on the end of the needle.
And I think it makes complete sense. It's, I think I go back to my early days of paramedic training where we talk about absorption, distribution, metabolism, excretion with all drugs. And, I think just to be, really, really clear, it's for those unconscious patients requiring positive pressure ventilation, they're crashing, they're hypoperfused. It makes complete sense that anything that you give intramuscularly just isn't going to cut the mustard, whereas, for almost any other group of patient in that state, we would always give drugs intravascularly. So I think it's, it seems like it's such a simple sort of mind shift change, but actually, like, again, anecdotally, I know that these patients respond, and as you've already alluded to, they respond so well to pharmacological input. We carry intravenous salbutamol in the UK, and again, like to see the benefit that has with these patients, and you can really pull them back from the edge. Thanks, Ben. The other thing that's really clear, just looking at the algorithm, is there's a real push for I'm sort of not wanting to use the word aggressive, but in a positive way. It's early requirement, recognition, and requirement for intubation, and I think that's it almost feels sort of strange in the current or recent climate where intubation's sort of almost been de-emphasized, really, certainly in UK practice, and we're often taught in life-threatening asthmatic patients, for example, that it should only ever be a last resort because it seems like not just an extreme intervention, but potentially that it carries high risk, and the patients then do less well, perhaps because of the things that you've been talking about, and again trying to get it within that hypoxic patient within a certain time frame. And I think this is where the algorithm is really good, because actually it encourages practitioners to read between the guidelines and understand there's a time for specialists to be specialists and need to do specialist skills. And I think that the algorithms for specifically critical care teams and resource teams in hospital, is that correct? This isn't a
Well, it's for anybody who is capable of intubation and who would call themselves competent at intubation. That's what it's for. So if you have that skill and you're competent at that skill, and that's part of your daily job description, then this algorithm is for you. And I think that there's a couple of points to say about the algorithm. That the reason we touched on it before, the reason why intubation is emphasized is because anaphylaxis and asthma both need high pressure ventilation if there's bronchospasm involved, and that can only be achieved with an endotracheal tube with a cuff, and an LMA just will leak, and a mask will inflate the stomach and cause vomiting, and which is aspiration, which is catastrophic. So there's all these well accepted reasons why a tube is so important in these situations. And you're right that I'm really glad that you've brought up this issue about particularly in pre-hospital medicine where intubation's been de-emphasized. But obviously it depends on what you put in the box of all of those studies that show, there's not much difference, but some of them show, well, the airway kind of fell out and we had to do something again. And so, there's still the definitive care when they hit the emergency department is a tube, regardless of what happens pre-hospital. But there are some people who need the tube in that pre-hospital setting, and this is one group. And I guess the question arises for your listeners who aren't intubating capable. And the only thing I would say is, after reviewing quite a few cases, is if sometimes it's tempting to pass off the bag mask ventilation to a junior person or a fire department person or whoever else is responding to the emergency. But actually, that needs to be in anaphylaxis and asthma. That actually needs to be the most senior person, because the oxygen is a thing that's almost certainly causing the problem. And if it's just the blood pressure that's causing the problem, that's going to get better with your adrenaline as part of this AMAX4, as the A part of the AMAX4. But it is really important to do that quickly. And it needs to be a tube and not anything else if you have that skill. And the second thing that you touched on is about the asthma cases, where we're told there's this dogma that say you don't intubate asthma, and that is absolutely true. 100% true. We don't intubate asthma if they're awake. They have to, if they're awake, I don't care what you do. Like you try your NIV, salbutamol infusion, your magnesium, whatever's in your kit, in your local guideline, you're giving it to them, and you're really hoping that they turn the corner and that you're going to get out of intubation. Because once you intubate them, yeah, look, it is difficult ventilation. And so we do everything we can. But if they are unconscious and hypoxic, that dogma does not apply. That is not part of this basket. That is a different situation. So now we're in a situation where actually the only thing that's going to save them is a tube. And yes, it is going to be difficult ventilation after that. And yes, we need a strategy about how to give small breaths with high pressure. So giving hard breaths with a bag, but only making them small and letting expiration occur so there's no gas trapping. And that's the X part of extreme ventilation as part of the AMAX4 algorithm. But it really is a different, that dogma about asthma is wrong, categorically wrong to apply that to a hypoxic unconscious patient. And so we just need to distinguish that as a critical care community.
And I think that's again, like you sort of said, it's not you're almost not reinventing the wheel here with the algorithm, but actually it's putting a clear emphasis on this very specific subset group of patients, and emphasizing the absolutely correct and immediate interventions that are required. And I'll share the algorithm will go on the podcast on the webpage, and I'd encourage everyone listening to have a look at it and go on the AMAX4 website as well. But just to I know we jumped around it, just to quickly run through it there. So the AMAX4 stands for A is for the adrenaline, so giving it intravenously 1 mic per kilo. The M is for muscle relaxant. First and only attempt at laryngoscopy must be the best attempt. So everything that we were always taught, to optimize the first attempts. A is for the airway, and this is the next bit that I was really keen to talk about again, because I think perhaps for some people maybe reading it or looking at it outside of the critical care world perhaps might feel that this is quite extreme, but there's a real push here and an advocacy for, if there's an inability to intubate first attempt, really is to be moving on to front of neck. And the thing that I really like about the algorithm is it puts in this hard stop of 4 minutes, which is the last part of the algorithm. I've not done a great job here. We'll go through the X's in between as well. But the hard stop and the focus on getting this airway and actually moving to front of neck. Can you talk a little bit about that, Ben?
Yeah, for sure. And don't worry about the algorithm. If you can't remember what AMAX4 stands for, it stands for gives them adrenaline and intubate them in 4 minutes. So that's it. So the Max, it's convenient that it's Max's name, but it could have been anyone's name if they were named Max, but it's maximum 4 minutes. And those human factor, those are 2 human factor things. So the muscle relaxant is to get you to commit and say, look, I'm giving the muscle relaxant, we're doing this. And the 4 is to say, yeah, and I'm going to do it in 4 minutes. So that's the start and the end, is really to get people to commit. So that's the human factor elements. But in terms of having just 1 attempt, I think that the best thing to do is that these people are silently, their brains are dissolving and they're becoming disabled in front of you, but without the drama of bleeding or penetrating injuries or gunshot wounds. They're just silently dying, and their brain cells are silently, so they can't advocate for themselves. And if we just take 1 minute to get all of your listeners to just imagine a resuscitation scene where there's an asthma or anaphylaxis arrest who's unconscious, who's just had a short period of mask ventilation, and we've committed and given muscle relaxant and we're intubating them, but we can't see the cords for whatever reason. Is that because there's vomit or because there's some edema? It's just not happening for us today. And on a different day in different circumstances, it might have, you can do it with your eyes shut, but this particular time, for whatever reason, it's not working. Now, the patient can't advocate for themselves. They're totally in your hands. And if we float above this resuscitation scene that we're visualizing and we look down from a few meters above and we just look at the patient, and the patient's brain is going to start dying. And let's just imagine what the patient would want you to do. Would they want you to keep having a few goes, or would they say, I don't care how if it was Max, he would say, I don't care how you fucking do it, just do it. he would, yeah, sorry to use the F word, but that's what he would say. And that's what you would say if you were the patient. And that's what I would say. And that's what anyone would say. I just want some oxygen. Please save my life. And so if you can, and that includes cutting the neck. I don't matter what you do. I'm unconscious asleep. I like just do what you have to do. And so if we can just imagine what the patient would ask you to do if they could talk, and if we do that now so that in the heat of the situation, we already know what the patient would ask us to do, then I think that makes that decision a lot easier, because I think it's not a complicated procedure. As long as you use your finger and get your finger in that sort of hard cage, then that hard cartilaginous cage, it's really a straightforward procedure. But knowing what the patient wants is really important, because that's what we're there for. And I think that's the nicest way to think about it. And you've only got 4 minutes to do it.
I think that's great, Ben. I really do. And, I think we often talk about sort of like the hallmark of a good clinician being someone who treats their patients as if they were their own family, or be happy if they were to treat someone in your family type thing. And, from what you said there, I'll go one further, and I think back to you in the resus room with Max, and how involved you became and ended up directing and leading on the surgical airway for Max. And I sort of think that, that's how we should be. We should almost be putting ourselves in a parent's or relative's shoes, and being confident and getting on with what needs to be done. I guess there's a big emphasis here on the need for regular, repeated training as well for these types of situations with less frequent presentations.
Absolutely. It's that high acuity, low occurrence situation that we sometimes talk about. And I've actually got this program that Rich Levitan, he's a good guy in the USA. He's an airway guy, and he's made some models, and I'm trying to, I think I'm going to spend money and buy every single emergency physician in Victoria a model so they can do just that, and that is practice and do some research before and after. But that's one of my projects, hopefully for this year. But yeah, thinking it's all about what we do beforehand. Practicing beforehand. So it's just like, yep, we know what to do. It's brainstem when the time comes.
And recognizing these cues, you talk about it, this hypoxic brain injury, like the time it's so short, and perhaps it'd be a good question to ask why that time is so short. But we talked about these cues, and obviously you've spent a lot of time researching and looking at other cases, particularly in Australia. There was another one that I remember watching from your lecture series. Could you maybe talk a little bit more about why the time to hypoxic brain injury is so short in this patient group, just to really emphasize the need for this hard stop 4 minutes, but also the other cues, things for practitioners such as myself and likely people listening to be picking up on, to be thinking this is the way that things are progressing.
Yeah. So maybe the second question first. The way that I think after spending a long time thinking about this, if things are getting worse despite 2 doses of intramuscular adrenaline, then you should be prepared for escalating all the way to AMAX4. And you might exit and things might turn the corner and you might reach the peak before having to intubate. But if things are still going after 2 doses of adrenaline, then you're like, get some help. Like you just, that's your cue. So hypoxia getting worse after 2 doses, blood pressure getting worse after 2 doses, agitation getting worse after 2, whatever it is, patient looking sicker after 2 doses, then that's an easy cue. And of course, the people who get sick before then, or they've arrested just as you arrive, or whatever. There's lots of variations, but as soon as people become unconscious, that's when the clock starts ticking.
And I know this.
Yeah.
Sorry, I was just going to say, I know for some other cases as well, and you touched on it as well. There's this. It's really common that there's this. Like it's listening to the patient. I think it's there's a almost. I wonder sometimes if it's our own wanting to reassure ourselves that we're perhaps not necessarily dismissive, like intentionally dismissive of what a patient says, but it's almost our like trying to reassure ourselves that the situation is okay. When patients are trying to tell something, I know in Max's case, obviously, it's harrowing listening to you say him saying that he felt he was going to die in the ambulance, but this is something that is quite common. Is that true? And a real cue for us all to pick up on, to think, this person's really sick. We need to get ahead of this now.
Totally. If someone says they're going to die, you need to believe them. And that's, whether that's James Sindos in Victoria, my Max, or even James Atkinson in the coronial thing that's happening at the moment. He said he was going to die in the back of the ambulance. So it's very common. And if that's combined with wheeze or hypoxia, then that's literally they're going to respiratory arrest in you in the next few minutes, probably. The other thing is incontinence. Incontinence in particularly in anaphylaxis. There was a good study done in Australia by an emergency physician which was emphasizing venom and blood pressure problems as the mode of deterioration, but incontinence is a sign that we're not perfusing like our gut and our brain's having this vagal reflex or whatever the mechanism is. But people tell you they're going to die, that they say they start sweating and they got progressively worse vital signs and become incontinent. All of those things mean they're about to arrest. So that's quite useful.
I think
literally, if someone became incontinent with anaphylaxis, I'd be getting close to being incontinent myself, unless I had enough help to navigate what's about to happen.
It's that really old school mantra of like looking at the patient and listening to the patient, and I can only imagine the ambulance crew who were with Max or in a similar situation, and how there's always this. Especially when you're new, you're looking at the monitor, you're looking for almost changes in physiological signs, whether it's hypertension and things like this. But we know that they're such late features, and actually that these subtle cues where time is everything will present so much earlier. So I think it's great. It's really, really good stuff, and there's some really, really powerful stuff in here for people.
Yeah, I totally agree with you. Like I couldn't say it better myself. Well, we were about to talk about something.
So the time to hypoxic brain injury.
Yeah. So what's really important to understand is that it's probably less than 4 minutes. Like if you think 4 minutes is too long, you're probably right, because that's one point of feedback I get, particularly from anesthetists who have got tubes galore and ready to go. But it's the fact that the reason you're unconscious almost certainly is because you've got no oxygen, and so you've already deoxygenated your whole body. And sure, it might be a blood pressure problem in isolation if it was a venom thing, and maybe, but we don't know because they're unconscious, and you can't be too sure. So let's assume that it's hypoxia, and they've deoxygenated their whole body, including their brain, which is completely different. So to VF, so you get a 50-year-old man with classical VF. Their stats were 100 when they dropped dead, in the classical situation, assuming they're not already in pulmonary edema and all these sort of things. But their stats were 100, and if you bag mask them, their lungs are working. And so, but with the asthma thing, the bag masking is not going to suddenly make their oxygen better without some really high pressures. So it's really short. It's really, really short. There's some, I think it's just because that's the mechanism. There's some allergist conversation that maybe there's some mast cells in the brain or something that makes it quicker to have hypoxic brain injury. I don't think that's true. I think it's just a fact that you've deoxygenated yourself, and the time's really short then, and parts of the brain that have the highest metabolic rate die first, and that's the basal ganglia, which means you're quadriparetic, and then it's invariably the hippocampus first, so you lose your memory first, and all of these things. Some of these things will come back if you just get in time, but if you let it go, then it's permanent or it progresses to brain death. And yeah, it's really short, and you can't extrapolate all of those, long CPR cases that you had a good outcome from. Like, that's not this. It's different. You can't apply it. And it's really important to say that CPR is probably not going to help. You're just circulating deoxygenated blood. So it's the oxygen. It's the ABC approach that's going to help these people. I'm not saying don't do CPR, don't get me wrong. What I'm saying is do CPR, but don't let that get in the way of actually fixing the problem, which is intubating people or giving them oxygen and adrenaline.
It seems like such a common sense approach from what you said, and very much in the same sort of vein as how we approach traumatic cardiac arrest, where it's correcting hypovolemia, oxygenation, and tension, and sort of correcting those things first, and not letting compressions get in the way, because generally, if you're going to be doing compressions, you're either pumping an empty heart, or one with a tamponade, or it's an obstructive pathology, or they bled. So fix those things first, and then it makes complete sense.
Yeah, exactly. That's hitting the nail on the head. And so there's just these situations which need a specific algorithm. We know what to do in trauma. We just decompress everything and give blood volume and stop the bleeding. And the same in asthma and anaphylaxis. It's a specific thing, and that's AMAX4.
And I guess as well, I'm perhaps speaking out of turn here, but having not unfortunately been in a situation where I've had to do any surgical airways, but you said that these are all relatively typically they're young patients, so I'm assuming when it for front of neck, it's assumed that most of them will have relatively easy to landmark anatomy. Is that a true statement, do you think, Ben? Is that fair?
I don't know. I'm sure there's my hope is that people will extrapolate Max4 to any asphyxic arrest. So if you're choking, or you've given some sedation, or you've tried to intubate, and all of a sudden there's vomit and you can't see an airway, you've got 4 minutes, because it's a type of asphyxic arrest which is akin to asthma and anaphylaxis. And so I don't know that it will always be easy. I think in anaphylaxis patients and asthma patients, it's quite often likely to be easy, but like you say, you need to practice it. But once you get the idea of just scalpel, and if you it's easy to get your finger in. So all you need to do is make a cut, whether it's, I teach vertically, and then you make a stab in the cricothyroid membrane and you put your finger in. And once you've got your finger in, you can't feel like it's in the wrong place. And so, you can poke your finger around and wiggle it around until you're in the right place, but you'll get there, I promise you. And this is assuming you've trained and understand the procedure. And yes, it's a very rare procedure, right? It's uncommon, and but that doesn't mean that it might not be you having to give it a go. On your next shift, it's totally unpredictable when these things happen. But yeah, so don't be scared is the idea. And if you've got multiple hands and someone else is trying to have a go at intubating at the same time, that's okay. Whatever you need to do to get the tube in, if you need to improvise. But the high performing teams have got their algorithm. Like Sydney Hems, I talked to. I felt like I was preaching to the converted. I know you do some flying as well, Alec. But yeah, you just have your mantra. What are you going to do? And you can have a 20-second checklist, and if I can't see it, then I'm going to move around, and you're going to cut, I'm going to do this. And yeah, it's just about that pre-practice. But don't be scared. It's not hard. It's actually easier than intubating. Like literally, it's easier. It's just like putting a hole in something and putting your finger in and putting a bougie along your finger. If you can, yeah, it's easy.
We often say to people that the hardest part of intubating is laryngoscopy, getting a view in the first place, right? And if you can kind of remove that whole element of intubation and externally landmark, and I remember someone really somebody saying it should just be seen as another way of getting an airway. Not that anyway I'm advocating a gung-ho approach to performing surgical airways, but in this group of patients, if it's the thing that's needed, I really, and listening to you, I think it's something that we should all be ready, like you said, any day. Really put the emphasis on training and positioning, making sure if you're going to be at the left or the right, who's in the pass spot, declaring it being an airway emergency, and just cracking on. Yeah, I think it's all really good stuff.
I'll just tell you one quick story, and because I've talked to a lot of people, and in Australia we've got lots of outback remote practitioners who deal with emergencies infrequently, and I've had a couple of people actually say, Ben, look, I don't think I'd be able to intubate, because I just don't do it that often, but I'd be more than happy to do a crack. And they said, would you support that? I said, absolutely. If that's the way you're going to get an airway, you go for it. And it's just a no-brainer. Again, imagine what the patient wants, right? So the patient's there, you're above the patient. What is the patient asking for? They don't care. They just want to be alive.
And I think if your back's against the wall and that's the fix is to oxygenate them, then it's kind of doing what you need to do, right? And that's why I really, really like the algorithm, this hard stop of 4 minutes. I think it's great. Just as we come into land, Ben, finally, I'm just really, really keen to know what the feedback has generally been so far with the AMAX4 guidelines, and whether or not there's been any positive outcome stories from practitioners that have used it. I know it's still relatively in its infancy, but like I said, I know that just through social media and lots of free access med education, it's been something that's been publicised and talked about a lot. Have you got any cases of when this has been used or feedback from people?
Yeah, I do. So look, I often so it's made. So one of my old colleagues who said, "Oh, Ben, I did a cricothyroidotomy. It wasn't an anaphylaxis patient, but his threshold for doing it and intervening very comfortably changed completely after doing some of the talks." Well, the first thing to say is that not one person has said actually what you're saying is wrong. It's because it's all accepted stuff. It's just putting it together. It's just universally, like everyone says, yeah, that makes sense. And so it's made it into some of our pediatric emergency books in Australia, and emergency guidelines. Will be a textbook in shortly, etc. So I think it's accepted, and eventually I'll actually publish it properly in a peer-reviewed journal. But just to finish off, there was this, Scott Weingart runs a podcast in the US, and one of his listeners posted an AMAX4 situation where he said, I've never given so much IV adrenaline in my life, and I intubated him, and it was really hard. And the dad was standing next to me, but the kid walked out of hospital. He was a 16-year-old boy, just like Max, and he walked out of hospital a couple of days later. So, that's, and he said, I wouldn't have done that if I hadn't have listened to the podcast. And so that kind of was mission accomplished for me.
I bet, and as I said before, I can't think of a more fitting tribute or legacy to Max. And I really do commend you for your courage and for the work that you put in such a relatively short space of time. It's been 2 years since Max's death, and I think it's incredible what you've achieved. And I hope the same as in the States, there's other people that listen to this and take it back to their own systems, and cause us all an opportunity to reflect on how we go about these things. To really overcome this decision and team inertia that can happen in these situations. But Ben, it's been brilliant to have you on. Thank you so much for your time and sharing your story. I really appreciate it. And
No, thank you, Alec, and to all of your listeners and subscribers. Look, I hope everything goes well, and I'm right behind you. I know you guys want to do a good job, and you do the most important job in the world. So never forget that.
Thank you very much.
Take care, Alec.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.